All right. Alrighty, let's get started. Thanks again for everybody joining us. And this week we're going to talk about pediatric fractures. But first, Joe is going to do a little review of his topic last week, which was hip arthroplasty. So we'll have some review questions. If you guys have any questions at any time throughout the talk, just comment on it, and one of us will be monitoring the chat. And, we could go through questions as we go. So this is the first question.
Yeah, so I wasn't planning on doing a full topic review. If anybody has any questions about it, we can certainly hit some of the highlights again, but I was just going to go through a couple of questions that would hopefully be fun for kind of reigniting it a little bit. So question number one here, we have, what is the most common complication in common combination under modern total hip arthroplasty? A cemented femoral component with a cemented acetabular component, B, a cemented femoral component with a non-cemented acetabular, or a non-cemented femoral with a cemented acetabular component, and finally D, non-cemented components for both. And we should be able to use the polling feature.
It's up. People are commenting in.
So what's the indication for this total hip?
Oh boy. I circumvented that question, Jeffrey, by saying most common.
All right, we're at 50%. Give it another couple seconds. Alrighty, let me end this. And can you guys see the results?
Yes.
Yep.
Alrighty.
So we had most common answer was cemented femoral component and a non-cemented acetabular component. So that, I would say, is the second most common current modern combination. And it is still used with a somewhat high frequency in Europe. But in the United States, we have, for primary total hips, in those who can tolerate it, we have almost entirely gone to non-cemented femoral components and non-cemented acetabular components. So what that means is you are impacting the implant, the prosthesis into place, and you're relying on a press fit interface between the bone and the prosthesis in order to gain immediate stability so that piece will not move while the bone grows in over the ensuing months. And then you have what we call osteointegration, or a biologic fixation, where the bone actually joins with the prosthesis. We discussed last week that sometimes you might not want to do that for the femoral component because you're having to hit it with a mallet, and like a log splitter, that femoral stem can, if you're hitting it too hard or if the bone is particularly weak, it can split the femur. You can cause a femur fracture with that. So Dr. Rossman mentioned a couple of times when he would prefer to use a cemented femoral component because it's a little bit more gentle. There are some finicky aspects of it that you have to be very careful about how you place that component. But there is pretty good data, pretty good literature that a cemented acetabular component has a higher failure rate than a non-cemented acetabular component. So it's pretty rare now to see a cemented acetabular component. It pretty much has to be not possible to do a press fit or non-cemented acetabular component in order for a surgeon to go that way.
All right. On to question number 2. Oh.
So this picture I included back here, you can see, well, you can't see my cursor. Jeremy can show you the roughened surface of the femoral stem. That part is, it allows bone to grow onto and into the little interstices of that textured portion of the implant, and same on the acetabular cup. So you actually get bony ingrowth that then fixes it. Grit blasted is far inferior than a manufactured texture. Just wanted everybody to know that grit blasted is useless. All right, next question. What are posterior hip precautions? So these are what we instruct patients on, and we want them to avoid certain positions. So is it A, we want them to avoid adduction of the leg and extension of the hip and internal rotation? Or B, is it abduction of the hip and flexion at the hip and external rotation? Or is it C, avoid adduction, flexion, and internal rotation? Or is it C, avoid extension, internal rotation, and torsion? Ah, Jeremy.
What?
You put the answer up.
Oh, sorry.
All right, so let's talk about why. So the reason,
Most people got it right anyway. So
yeah, so the reason we call it posterior hip precautions is because the most common direction of dislocation is posterior hip dislocation, meaning the femoral head falls out of the back of the acetabulum, and that applies for a native hip, or for a prosthetic hip. And it most commonly goes that way because, for a number of reasons, that's the direction of most of the muscular pull. That's the direction that it is put into a precarious position in our most common activities of daily living. And the reason that becomes pertinent to our discussion of arthroplasty is that probably I would just make up a percentage. I don't know what proportion of surgeons across the United States are using a posterior approach, but it's still a pretty high percentage. And when you go from the back, if you remember from our discussion last week, we call that the Moore or the Southern approach, or a posterior approach. You're splitting through the gluteus maximus. You're coming down to the back of the femur. You take down the external rotators, the piriformis, the superior and inferior gemelli, and then you are taking the obturator internus, and then you have to split the posterior capsule. You have to do a capsulotomy. And so all of that is destabilizing the back of the hip joint, which we already know is the way that it wants to dislocate when an appropriate force is put there. So in those patients who have a posterior approach total hip done, we want to protect them. In other words, limit them from doing the actions that would put their hip at most risk for going out the back. And incidentally, it makes sense that this position is the same position, the same forces that we apply when we are in the operating room and we're trying to dislocate the hip. When you're trialing, you're putting your femoral head on, you're putting your cup in, you're seeing if you like it, and then you dislocate it. The way you dislocate is you flex the hip up, you drop the knee to the table or adduct it, and then you internally rotate and it pops out. So we just tell the patient to avoid those positions, and we instruct them. And commonly when they're asleep in bed, because they could roll over and can't control their body, we typically strap them to a triangular pillow that keeps their legs in an abducted position, which is protective. Okay, so we don't have too many questions, so we're moving here. So question number 3, what would happen if you increase the neck length of a femoral implant? Would it A, increase the length of the limb overall? Would it B, increase the offset and therefore improve the abductor tension on those muscles? Would it C, cause an easier dislocation? In other words, would it destabilize the hip? Or D, is it A and B? We have a quorum. Nice. 78% of people got that right. That's great. So B is definitely correct, but A is also correct. So therefore D is the correct answer. C is incorrect because by increasing the length of the neck, you are both increasing the length of the leg and increasing the tension across soft tissues, as well as increasing the offset, meaning the distance from the ilium or the lateral border of the pelvis to the trochanter so that the abductor muscles are also tensioned, which only sucks it in tighter into the cup, which it would actually make it harder to dislocate. So if you hit one more click, Jeremy, I think there's an illustration. So if you guys remember this from last week, ignore the gray implant in your mind and just look at the gold and the bronze implants. Those are both 133-degree implants, and you're going from a standard offset to a high offset. That high offset, all they are doing is they're increasing the length of the neck of that implant. And remember, the neck of the implant is a hypotenuse of a triangle formed by the x-axis, which is the distance from the ilium to the trochanter, and the y-axis, which increases the length of the leg. So if you increase the hypotenuse, you're increasing both. Oh, I meant to put that one as a animation to show up later. My apologies. So, in which hand would you advise a patient who has hip arthritis to carry their cane in order to decrease the hip reactive forces, and why would you do that? Is it A, carry it in the same side as the affected hip so that you can lean over on the cane, or B, in the opposite side of the affected hip so you can lean away from it and better lift up the hurting hip? Is it C, the same side as the affected hip because, well, yeah, that just makes sense? Or is it D, the opposite side because of the larger lever arm that decreases the tension that the abductors have to generate? And I'm not a good question writer, so test taking skills should make it obvious that D is the right answer. So if you show that illustration behind the pole, Jeremy, if you guys remember from this that the center of rotation for each hip is the center of the femoral head, and that is a balance beam. And the two forces that are acting on either side of the balance beam, on the midline is always the center of gravitational force pulling the pelvis down. And the other side of that is the tension generated by the abductors. So since A is a shorter distance than B, the abductors have to pull extremely hard in order to level the pelvis and prevent it from falling into an obliquity. If you were to carry a cane in the opposite hand, meaning away from it, it would decrease the forces seen on B and therefore decrease how hard A has to pull to keep the pelvis level. And therefore, that is the way that you decrease how tightly the abductors actually pull the joint into place, and it actually decreases the forces that are seen at the hip. We do that same thing for a same application of that principle we talk about in femoral neck fractures. It's beyond the scope of this talk, but we come at that all over and over and over again, that those hip joint reactive forces, because of the muscles that are pulling the hip into place, we find ways of neutralizing those forces.
All right. Before we go on last question, bonus. Forgot about this.
Oh boy, that is a good bonus question.
All right, let's launch it.
I'm going to answer this one.
Dr. Scheinman, you're welcome to answer this question as well.
Yes. Oh, man. This is the only question that we got over 75%. All right. Let's share the results. So Galloway, what's your thoughts?
I love it. I love pineapple on a pizza.
I'm with you. What about you, Jeff?
Nope.
Get out of here.
There's so many other better toppings.
So before we go on to peds, anybody have any questions from what Joe just went over, or anything from last week that we want to touch on real quick? If not, we're going to go on to this lecture, which is going to be on pediatric fractures. So one of the first objectives is we need to understand that children are not little adults. And so there's a bunch of things that we'll go through in this talk that
Totally disagree.
are a little bit different, and you have to realize and treat them differently. Also, in this lecture, we hope to understand principles specific to pediatric fractures, understand physeal injuries and what classification system to use, and then get a little bit of an introduction into specific pediatric fractures, ones that we see commonly, and then how to manage them and what their treatment options are. So first we'll go into just the general principles specific to peds. We'll talk about physeal injuries and the Salter-Harris classification. And then we'll go into common fractures, which we'll break it up into distal humerus, forearm, and ankle. But before we go there, we'll go through a case, and then we'll just touch on it right now. So I want you guys to just think of this, and then we'll go through it a little bit later. So this is a 4-year-old female that the peds ED is calling because she fell out of bed and she's complaining of right elbow pain. And they obtain these x-rays. So here is an AP and a lateral of the elbow. And you can see a fracture through here. And we'll get into some specifics of this type of fracture in a moment. So just think of this, think of what you guys think you would do, what initially, and what types of treatments. So let's talk about some just general principles of peds. So there's a little bit of differences in just how you take a history and physical, because in younger patients, they're going to give you a limited history. Some of them can't talk. Some of them are scared to talk. So initially, when I see a pediatric patient, I try to involve them if they're of age to talk, and just ask them simple questions like, hey, buddy, how'd you get hurt? What hurts? Can you point to where it hurts? And then you can involve the parent and get some more additional information about the specifics of the injury, and then especially about their past medical history, if they have any allergies, things like that. And then pediatric patients are sometimes difficult to examine, partially because they're scared of their injury. They might be scared of you. So I think it's important to examine the known injury last. So if you know that they have an elbow fracture, check out their lower extremity, check out their other uninjured arm first. I think that's an important thing you can do for adult patients as well. And then lastly, whenever I see a patient, I kind of trick them into participating in the exam. So you ask them to give you like a high five or kick your hand, and that way you can check to see if they have range of motion, if you're concerned, if maybe sometimes we get consulted with negative x-rays, but they have decreased range of motion. So that can, kind of course them into giving you a better exam. And then I just wanted to include my nephew here just because he's super cute. So there's some unique principles to peds, and the first one's elasticity. So in adults, a lot of times we'll get complete fractures, but in peds, you'll get either a buccal fracture or a green stick. And a buccal fracture is a plastic deformity of the bone where you get some compression. And you can see here in the picture, on the radial side, you just kind of get this buckling of the cortex, which you can see more pronounced on this lateral x-ray. And the way I kind of think of it is if you have a throw rug on the ground and you're like running into it and you kick it, it kind of bunches up on one side. So that's similar to what a buccal fracture is. And then a green stick fracture is an incomplete fracture where it may only be fractured on one cortice. And then a lot of the times you'll also get some plastic deformation or a bending of the other cortex. Another unique principle to peds is they have a great remodeling potential, and that's for a couple of reasons. One, they have open physes, and so there's different physes that will have a little bit more remodeling potential because they're more active. And so when we look at the upper extremity, the proximal humerus is going to be more active than the distal humerus. It's about 80% of growth of the proximal humerus and 20% of the distal humerus. In the femur, most of the growth is coming from the distal femur, where it's 70%. And in the tibia, most of the growth is coming proximally with 55. You can also, a good way to think about this of where the most active physes are is imagining someone sitting in a bathtub. And so anything that's above the water, so the knee, the shoulder, the distal radius, that's going to be your more active physes. And then you can also think about where the more active physes are by amount of growth per year rather than a percentage. So a lot of the times we talk about the lower extremity, and we get a bunch of questions on our in-training exam. And so the distal femur is about 9 millimeters of growth per year. So almost a centimeter of growth per year. The proximal femur is 3 millimeters, proximal tibia is 6, and the distal tibia is 5. And the way I just initially remembered this when I was first starting out was I knew that the distal femur was 9 millimeters or close to 1 centimeter. And then I remembered that the proximal femur was 3. So then to get the tibia, I subtracted 9 minus 3 equals 6. And that's what the proximal tibia is. And then I just remembered 1 less is the distal tibia. That's just how I kind of remembered it initially. So also with the remodeling potential, the joints that are in the plane of motion are going to remodel better. And so you can accept more of a deformity in that plane. So an example of this is a distal radius fracture. You can accept more deformity in the sagittal plane, so a flexion or extension deformity, because the wrist flexes and extends. That's similar to a distal humerus fracture. You can also accept more in the sagittal plane because you have elbow flexion and extension. So next we'll talk about physeal injuries, and this is the Salter-Harris classification. So it's 1 through 5, and the first is first is a type 1, which is a physeal separation. So the energy of the injury goes directly through the physis, and you oftentimes will just see some widening at the physis, or sometimes you'll see a complete separation or where it's completely slipped off. Type 2 is when the energy first transverses through the physis and then it exits in the metaphysis. A type 3 is when it goes through the physis and then it exits in the epiphysis. 4 goes through both the metaphysis, then through the physis, and then the epiphysis. And then a type 5 is when you get a complete crush injury to the physis. So another way of remembering this is if you take the word Salter and you get rid of the E, and then you apply it to the 5 types. So a type 1 corresponds to S of Salter, and the S stands for slipped. So again, it's a injury through the physis. Type 2 is A for above, and that means that it's above the physis, so it's through the metaphysis. L is for type 3, and that stands for lower, and that's going to be below the physis, and so therefore it goes through the epiphysis. Type 4 is for T, which stands for through, and that's going to be through the metaphysis, the physis, and the epiphysis. And then type 5 is R, and that can be either for rammed or ruined, and that's a complete crush injury to the physis.
Jeremy, can I pipe up here?
Yep.
So another way of remembering this, and for me, it was always, it made sense that 1 and 4 and 5, you remembered that, you kind of remembered the overall thought of it. It's like, okay, 1 is like a slight injury and then 2 and 3 are like, it goes one way or the other. And then you remember 4, okay, it goes all the way across. And then 6, you just remember it crushes. But I could never remember which one was 2 and which was 3. And I like this Salter thing. That's a really nice way of remembering it. But the way I kept 2 and 3 straight was I just remembered that 2 is the prefix for 2 is di, and so that's the diaphysis. And then 3, you just say 3 is E, and that's the epiphysis.
I like that.
Yeah,
that was it.
That works well. The big key with Jeremy's tip is you have to remember it as an ankle, because if you start talking about these injuries as up around the knee, or if you flip a distal radius around, you'll start usually getting confused what's above and what's lower.
Yeah,
So
like for the
remember that
proximal humerus, if you say 2 is above, that could potentially confuse you. But you can always remember. For me, it was the di, and 3 is E.
Yeah, I like that. I never heard that, and I think that's a great way of explaining it. So what happens if you get a physeal injury? So you get a growth arrest. So if you have an injury completely through the physis, then it's going to affect the whole physis, and you'll get a complete shutdown there, and then therefore you'll get a length disturbance or discrepancy, which is pictured here. If you only injure part of the physis, you'll end up getting an angular deformity because one side of the physis is shut down while the other side is continuing to grow. So next, we'll start talking about some specific common fractures that we see in pediatric patients, and we'll go through the distal humerus first. But before we get to the specifics, we have to understand that the physis is a little bit different in the elbow. And sorry, I just noticed that I got this wrong. This is the appearance of the ossification centers, not the physeal closure. So the physis appears at different ages in pediatric patients. And so this I got from Ortho bullets, but a way to remember this is the use of this crito. And so the C stands for the capitellum, the R stands for the radial head, I stands for internal, which is the medial epicondyle, T is for trochlea, O is for olecranon, and E is for external, which is the lateral epicondyle. And then from here, these are more specific numbers, but what you can do is just say that the capitellum's 1, and then just add 2 years to each of them. So 1, 3, 5, 7, 9, and 11. And that gives you a general idea of when these are going to start ossifying. And so that's important because sometimes in pediatric patients, you're not going to see all, depending on their age, you're not going to see a complete fused, normal looking distal humerus. And then to confuse you even more, they fuse at different ages. Joe or Jeff, can you guys think of something if you're a little bit confused of if it's just a fracture or is it just an ossification center, something you can do in the emergency room to figure out if there's an injury to that elbow?
Sure. So when you're ever unsure with a kid, or for adults, honestly, and you're trying to figure out, is this normal? Is this abnormal? I don't really know. It's helpful to remember that you have a roadmap or a mirror image on the other side of the body. The patient has another leg, and that other leg is what is normal for them. So just take an x-ray of the other side. So for the elbow, it's like, all right, we got all these weird things going on. I don't know, is this a fracture? Is it not? Okay, just x-ray the other elbow. If the exact same line is there, then that's a physis. It's not a fracture.
Additionally, you have to really kind of plan on correlating your clinical exam to the images you're finding. Pain at the elbow doesn't mean that if there's pain on the medial side and there's a ossific line on the lateral side, you know that that's not correlated. Even young children who can't really explain what's going on will react when you push on a fracture. If you're pushing on just a epiphysis, the child likely won't react.
As long
and
as
you'll
you
be
don't
able to
push
use that.
really, really hard.
Well, yeah, you don't want to push through the epiphysis, but really just correlating your exam is really important as well.
That's great. That's great,
Does
because
it make sense?
that is what makes the difference in how orthopedists look at x-rays and how a radiologist looks at x-rays, because we have the cheat code. We've examined the patient. We've had the opportunity to examine and be able to push on areas and find out if they're tender there. So we interpret x-rays with an entirely different light shed on them than a radiologist is able to do.
All right, so let's talk about supracondylar humerus fractures, and this is the most common pediatric fracture. It's going to occur from a patient falling on an outstretched arm, often from monkey bars at the playground or off a bed, jumping on a bunk bed and whatnot. It's going to be usually in patients around 5 to 7, sometimes a little older, younger. And as we go through the classification system, 95% are going to be an extension type. And so that extension type is classified by the Gartland classification, and that's 1 through 4. We'll get through the specifics in a second. But then there's also a flexion type that's a little bit different. So type 1 is a non-displaced fracture. And so you have intact periosteum and cortex at the anterior and posterior aspects. So if we look at a radiograph, this is an AP and a lateral. You can see a line coming through here. And if you look on the lateral, you can see that line. And you see that the cortices are lined up. There's no deformity. It looks like a normal lateral of the distal humerus. So how do we do these? It's going to be a long arm cast for about 3 to 4 weeks. Type 2s are going to be displaced. And like I said, Gartland classifications are always going to be extension types. So there's going to be more displacement at the anterior cortex, but there's an intact posterior cortex and a periosteum. So it kind of just hinges off the posterior aspect. And so if we look at radiographs, again, on the AP, you're going to see this fracture line through the supracondylar region. But then on the lateral, you're going to see this deformity, how if you compare it to the last radiograph we just looked at, it's more extended. This anterior cortex here isn't in line with the rest of the humerus shaft. And so how do we treat these? Before we decide what we're going to treat, we have to assess what we call the anterior humeral line. And it's pretty much a line. What it says is a line down the anterior aspect of the humerus. And so you just draw this on your radiographs. And then you look to see where this line intersects the capitellum. So the capitellum is this oval ossification here. So if this line crosses the middle third of the capitellum, which is where it normally crosses, you can treat this, you can call this a type 2A, and you can treat that in a cast. If the capitellum is posterior to this line, meaning that there's more of an extension deformity, then you're going to treat this mostly with the closed reduction percutaneous spinning. This 2A versus 2B is very controversial, and if you get a room of pediatric orthopedics together, often they're going to say different things. Some people like you to push on the posterior aspect of the elbow and try to push or reduce this better to try to get your capitellum to intersect the anterior humeral line so you can treat it non-operatively. Others say you just go right to closed reduction percutaneous spinning. Your type 3s are going to be even more displaced. And again, it's going to be mostly in your sagittal plane, but now we have some coronal plane involvement. And so you still have a disrupted anterior cortex, but now we have a disrupted posterior cortex, but there's still some intact periosteum in the posterior aspect that's going to give it some more stability. And so on the radiographs, you can see here on the lateral, it's completely disrupted on the anterior and posterior cortices, as well as you can see this more deformity on the AP. And so to treat these, they're always going to be closed reduction percutaneous pinning. And if you have difficulty getting a good reduction, you may do an open reduction. Lastly, the type 4 is going to be your most unstable of your Gartlands. And you have to diagnose this in the operating room. So you can't just call a preoperative radiograph a type 4. You have to see it in the operating room, and it's because it's displaced in multiple planes. And these are, again, always going to be closed reduction percutaneous pinning, open if you need to, and you might be more inclined to open these because of the more instability. Our other type is our flexion type. This is the least common. Like I said before, 95% of the time are going to be extension type supracondylars. And the way these occur is you get a fall directly on the olecranon, and it forces the distal humerus to go anteriorly and get a flexion deformity. And you're going to treat all these with closed reduction percutaneous pinning, and you're even more likely than any of the other supracondylars to need to open these. So I've been talking about closed reduction percutaneous pinning. Let's just talk a little bit about more specifics about this. So the majority of the time, we're going to introduce our pins laterally, and this is because it's the safest. On the medial side, you have the ulnar nerve, and so you can potentially injure that if you introduce pins on the medial side. As you can see from these pins here, they're heading away from each other, meaning that they're divergent pattern. And because of the divergent, that gives it a more mechanical stability. And in general, we talk about type 2s are going to get 2 pins, type 3s need 3 pins, and then type 4s get 3 or 4 pins. And once we pin these, they're going to stay for about 3 to 4 weeks. So the next most common elbow fracture is a lateral condyle fracture. And what's different about this versus supracondylar fractures is that it's intra-articular. So you can see on this diagram here, the way you classify is the Milch classification, but you can see how it exits into the articular surface. And so it's going to be most of the time a type 4 by Salter-Harris classification, meaning that, again, it goes through the metaphysis, through the physis, and then the epiphysis. And a difference between Milch 1s and 2s is that the Milch type 1s are lateral to the trochlear groove, which is here, and the type 2s are going to go medial to that. And the consequence of going medially is it's a little bit more unstable. When you're looking in the emergency room, the internal x-rays, oblique x-ray is going to help you because the lateral condyle is a posterior lateral anatomic region. So by doing an internal rotation, that's going to show you your most displacement, and that's going to aid into your treatment. So the way we treat these is we look at the amount of displacement. And so if it's less than 2 millimeters, we can treat this in a long arm cast, similar to non-displaced supracondylars. If it's this gray area 2 to 4, we can do a closed reduction percutaneous pinning. And then if it's greater than 4 millimeters, we have to do a formal open reduction, get a better reduction of that fragment. And then often we'll put a screw there since we're open. One other thing to point out here is, if you remember from what I was just saying about closed reduction percutaneous pinning for supracondylars, we leave the pins in for 3 to 4 weeks. With lateral condylars, we leave them in longer for usually 6 weeks, and that's because of their intra-articular. And we want to make sure that we get a nice, a healing of that fragment.
That's a really interesting point to make, Jeremy, and that's applicable to a lot of other areas of the body. we won't really go into why, but you guys will find that injuries that involve the joint, in other words, where the fracture line goes into the joint, or even ligaments that are in the joint, they don't heal as well as things that are outside the joint. And you would have to dig into the basic science and talk about how synovial fluid affects healing. But injuries that go into and involve the joint universally on all areas of the body take a little bit longer to heal.
All right, let's move on a little bit distal and go into forearm fractures. So the both bone forearm fracture is a fracture through both the radius and the ulna. It's very common and usually from fall from height or from sports. Similarly, a little bit distal, the more distal radius fractures, they're going to occur in a little bit older patients, usually 10 to 14, and are all on the outstretched hand, usually with it. Yeah. So most of these are going to be treated non-operatively.
Jeremy, are you able to, somebody has their microphone on. I don't know if you can mute them.
Let's see. Yep, I think I did.
I think it's the person who's maybe from another country. I'm not sure. There we go.
Got it. You did. So not going to get into the specifics of angulation values or malrotation, but just wanted to draw your attention to looking at the age. So if you notice here, the younger patients are going to allow for more acceptable angulation malrotation. And that's due to what I mentioned before, is younger patients are going to have a higher remodeling potential. So the way that we treat these, like I said, non-operatively, you want to reduce these in the emergency room. Oftentimes, especially for both bone forearm fractures, we may ask for some sedation. If it's more of a distal radius fracture, you can just do a hematoma block, meaning inject some lidocaine into the fracture site, and that gives some very good anesthetic to the patient and helps them relax a little bit. For most of our fractures, the way we reduce things is we recreate the deformity and then put it back into its normal position. A trick, though, sometimes both bone forearm fractures are a little bit difficult to reduce. So a reduction trick for them is, you can just think of it by bringing the thumb towards the apex of the fracture. So if you have an apex volar deformity, so apex at the the volar surface, which is going to be more anterior, you want to bring the thumb towards that, so that's going to be pronation. If it's on the dorsal surface, you're going to bring the thumb towards that, and so you supinate the hand, and that may help you with your reduction. Once you reduce it, for both bone forearm fractures, you're going to put a long arm cast on. For distal radius fractures, you can sometimes get away with a short arm cast in older patients, but for younger patients, you're going to just do a long arm cast as well. And then when you reduce it, you want to get a good mold on your cast. And we have this phrase in orthopedics saying a crooked cast equals a straight bone. So you want to have a good mold, have it looking a little funny, and having the parents ask you, why'd you put this crooked cast on a kid? Because if you have the whole premise of getting a good mold is to preventing a loss of reduction. So you reduce it, but you want that reduction to stay. So you need to apply a force to hold that fracture in position. Another way of holding that fracture in the position is getting a good cast index. And so the cast index is a ratio of the distance from the inside of the cast on the lateral and the AP or PA, and that ratio should be less than 0.8. If it's less than 0.8, you have a good interosseous mold, you have a good mold on your cast, and that's going to hold your reduction much better. For some reason, if that doesn't work, other ways to treat both bone forearm fractures or distal radius fractures are a closed reduction, percutaneous pinning, flexible intramedullary nails, which are pictured here, or you can do an open reduction internal fixation. However, most of the time you have to go back for additional surgery and remove those. That's similar also for the flexible nails. You have to remove those in a couple months after as well. Next, let's go on to ankle fractures, and we'll talk about talon and triplane. But before, similar to the elbow, we have to talk about how the physis is affected. And so in this case, the physis closes a little bit different in the ankle. So instead of just closing just completely at once through the whole physis, it first starts centrally, and then it goes to the anterior medial portion, then the posterior medial portion, and then the last to ossify is this anterior lateral portion. And that is usually around 14 in kids. And so the way the physis closes is going to affect the way we have different fracture patterns in pediatric patients. And one of the most common examples of this fracture is very rare, but a good example of this is a talon fracture. And so it's a Salter 3 or Salter-Harris 3 fracture of the anterolateral distal tibia. And the way this occurs is a supination external rotation force. And because the anterolateral aspect of the distal tibia is still not fused in patients in 12 to 14 years of age, a ligament avulses that fragment. And so that ligament is the anterior inferior tibiofibular ligament, or the AITFL. And so you can see that here. This is the anterolateral aspect looking at an AP, and this is a sagittal CT cut looking at the anterior surface. And again, it's a Salter 3, meaning it involves the epiphysis. So how do we treat these? So first we want to reduce them, and then we check for the amount of displacement after. So to reduce them, a trick is to do some internal rotation, which is the opposite of the mechanism or force that caused the fracture. And then we put them in a long leg cast, and we check our displacement. If it's less than 2 millimeters, you can just treat them in that cast. If it's greater than 2 millimeters, we're going to do ORIF with a lag screw. And if you guys remember back to previous lectures, this is a lag screw by design, meaning that it's partially threaded. So it's going to allow us to get some compression across that fracture. And another thing to note in this x-ray is you can see the physis is here. And so we make sure that we introduce our screw parallel to the physis to injure the physis any further, because we already have some injury to the physis from the initial injury, but we shouldn't cross the physis because that will affect it and cause some growth arrest. The next is a triplane fracture. And again, this is a rare fracture in the ankle, but it demonstrates this way of physeal closure in pediatric patients. And so this is a Salter 4 fracture of the distal tibia. And it can be pretty complex, meaning that it can have up to 4 different parts. But what's unique to these is it's going to have a Salter 3 on the AP and a Salter 2 on the lateral. So when you're looking on the AP, it's going to look very similar to a talon, meaning that it has a fracture through the epiphysis. And then on the lateral, it's going to have a Salter 2, meaning it goes through the metaphysis. And because these fractures are within that plane, you can't see that Salter 2 on the AP, and conversely, you can't see the Salter 3 on the lateral. And just of note, this is going to occur in slightly younger patients than the to low, because if you remember back, the other areas of the ankle aren't fused yet. The anterolateral is the last to fuse. So to involve more areas of the ankle, they have to be slightly younger than patients that just have to lows. And so how are we going to treat these? It's very similar to low fractures. Again, we're going to try to reduce them. A lot of the times that internal rotation is going to help as well. And then we look at our displacement. Less than 2 millimeters is going to be, again, in long leg cast. Greater than 2 millimeters, we're going to fix it. And again, we're going to use partially threaded screws. Just one other thing to note, we didn't really mention this in previous weeks, but I think it's something to just touch on here. As you can note here, if I draw this fracture out a little bit better, so on the lateral, if you look, the fracture's here. And so you have this small triangular piece here, and then you have a much larger piece of the distal tibia here. But if you note, we put a lag screw from anterior, this is anterior, to posterior. And so we're only getting a few threads of the screw to engage here. So it's not that great of a mechanical stability to introduce an A to P screw in this area. So we always talk about, we say that, is it better to, do you hang a pitcher to the wall, or do you hang a wall to the pitcher? And it sounds pretty obvious. We all hang pitchers to the walls, meaning that we hang something smaller to a bigger fragment. So the smaller pitcher to the bigger wall. And so to get a better mechanical stability, you should hang this smaller fragment and bring it to the bigger. So if you wanted to get a better mechanical advantage or stability, you would place a screw from posterior to anterior. So that way you would get more screw threads in a much larger fragment. Now, why is this screw going anterior to posterior? The reason is it's much easier to position the patient supine when we need to place a screw from lateral to medial, and then as well as some sort of screw in the sagittal plane. So we kind of will do this sometimes just for ease of positioning and ease of surgical planning. All right, so let's just get back to the case. So again, to remind you guys, this is a 4-year-old female. She fell from a bed and she came with right elbow pain. And so now we have a supracondylar fracture. Anybody in the audience wants to take a stab at what type of fracture they think it is, or if Joe or Jeff want to explain what type of Gartland classification you think this is?
Let's give a second to see if anybody wants to venture a guess.
Alrighty.
Very good.
Are we getting answers?
Everyone. Yep. We're getting a lot of 3s or 4s, question mark.
Yeah. So
which is appropriate.
Yep. So it's most likely a 3, but however, you can't comment on if it's a 4 until you're in the operating room. So you can see here on the AP fracture there, and then on the lateral, you can see clearly the anterior cortex is disrupted, but you can also see that the posterior cortex is disrupted. Again, it's an extension deformity. And so, we already just described the fracture. We know that this is a type 3 or 4. Jeff, when you're seeing this patient in the emergency room, is there anything you're looking out for? Are you immobilizing this patient, and when are you going to operate on it? Say it came in 9.
An 8 p.m. kind of guy.
Yeah.
So basically, when you have these types of injuries, particularly you think about all of the important neurovascular structures that go across the anterior aspect of the elbow, because we have an extension deformity. Going back to the x-ray, you see there's a large fragment on the proximal fragment on the bone that can cause compression to your vasculature. So you want to check to see if you have a pulse. Additionally, there's a difference between warm pulseless and cold pulseless, essentially warm versus cold, essentially, which will help determine your urgency to take this patient to the OR. In terms of immobilization, this is not something that you're trying to reduce the fracture down in the emergency room. Again, even in the operating room, you're concerned that when you do reduce this fracture, that you may entrap neurovascular bundle, causing decrease in vascularity and blood flow distally. So you're, in this case, putting on a posterior splint, splinting in situ, making sure there still is a pulse because you are manipulating the arm, although minimally, while you're putting the splint on. And again, blood flow is your biggest concern in terms of whether you're taking the case tonight and calling mobilizing the OR for a 10 p.m. start or putting them on for first case in the morning. Additionally, since what run along with a lot of these vessels in the front are some of the nerves that go down to your hand, you're also looking to see if there's injury to any of the nerves down in the hands. For an extension type supracondylar fracture, you're concerned that the AIN nerve may be injured. This, you'd see that this child is unable to flex at the IP joint of the thumb. Again, can't make the AOK sign compared to the contralateral side. So again, make sure the patient knows what you're asking them to do to show that they can do it on the other side, to really prove that they can't physically do it. And then you're, again, taking this ultimately to the operating room for percutaneous pinning, possibly opening if you need to.
Yep. Perfect. Anything to add, Joe?
No, I think he hit all the highlights. Great. Yeah, I think the emphasis is always on the blood flow. The nerves are like important, and yes, we want to know about it, but the blood vessel is what's going to kill the hand and the forearm. So emphasis on what we're doing and when we're doing it is always on perfusion.
Yep. Alrighty, so we said this was a type 3, maybe 4. So we took it to the operating room, and we're going to do closed reduction percutaneous pinning. So how do we do this? And so there's a couple steps that you do with every supracondylar fracture to get a good reduction. So step 1 is you apply traction, and you do just some slight flexion, and that's going to bring it out to length. Once you get it out to length, then you want to correct your coronal plane. So this is going to be a varus or valgus force. And so what you do is you can see here that you usually have your non-dominant hand grabbing the humerus, and then the dominant hand is going to be down here at the forearm or wrist, and you're applying a valgus or varus force to try to correct that coronal plane. Once you are satisfied with your coronal plane, then you're going to want to correct the sagittal plane. And so the way you do this, as you can see here, is you flex up the elbow. And so often some other times you might have to direct a posterior to anterior directed force at the elbow. So you may want to do a force like this to kind of push that fragment anteriorly, because it's an extension type injury. Once you're happy with your sagittal alignment, then you're going to hyperflex, and you're going to start introducing your pins. And so, like I said before, lateral entry is much safer because you're staying away from the medial side, which has the ulnar nerve. And we're just taking pins and placing them percutaneously through the skin. So we're not doing an open incision. We're not looking for anything. We're just placing these percutaneously. And so we place our first one through the capitellum, which is here. and then through the medial cortex here. And then once we get that first pin, then we're going to introduce 3, maybe 4 pins, or if it's just a type 2, just 2. And we're going to, again, try to diverge these pins. So get a good splay and spread them out as much as possible. That's going to give us increased stability. And then on the lateral, we try to line these up as best as we can straight, but this is perfectly acceptable. And you can see here there's a nice reduction of the both anterior and posterior cortices.
So Jeremy, before we go ahead, there were a couple of really good questions. I want to start just because it's right at this moment with the last Eddie Gunty asked a nice question about expounding upon and clarifying the hot-cold feeling of the hand and the elbow and how that lets you know if the patient should go to the OR tonight or not. I think so. The big thing is to understand that in order to feel a palpable pulse, if you remember back to the physiology lectures that you've had on blood vessels and the elasticity of blood vessels, that there has to be a strong enough flow making it through all the way down from the heart to the aorta, the large vessels down to the small vessels, that then there can be a rebound that you can palpate with your fingers. And that's what you can detect on your physical exam as a pulse. Now, the absence of a pulse itself does not mean there's not blood flow going to the hand. It just means it's not going in robust enough of a fashion that you're able to detect that. So the real question that you are trying to ask when you're seeing this patient in the emergency room is this hand going to die if I don't do something about it right now? And so if you have a patient who has a deformity and has a bad x-ray, an extension deformity or flexion, and you are feeling you can't find a pulse anywhere and their hand is cold, that cold sensation means there is no warm blood getting there. That hand is in the process of dying, and you need to do something about it now. So that is a pulseless, cold, cool, sometimes blue hand. Now, if you have the same situation, you have a bad deformity, you have swelling, you have an x-ray that looks like crap, the distal humerus is in outer space, and you can't find a pulse anywhere, but that hand remains pink. There is capillary refill in the fingertips, and the hand is still warm. It just means that there is some degree of injury to the blood vessel, and maybe it's not even an injury, maybe it's just the blood vessel reacted, and it's a 2-year-old child and they have incredibly robust physiology, and that artery clamped down really strong because it has smooth muscle fibers within it, and so the blood flow changed to a way that you can't pick it up with your fingertips, but they are still getting flow to the hand, and that hand is going to survive. And so there is less of an urgency or an emergency to take that patient right then and there to the operating room. Does that help?
There's a whole algorithm on this topic, and there's also, sometimes you're in the operating room and you reduce the fracture and then you lose the pulse. There's different algorithms of what you should do at that time. It's a pretty complex subject, but I think what Joe said just is a good overview of it.
Yazan had a great question. I want to answer that one actually after the summary because it kind of requires us to deviate and go back a topic. But before we leave this one, I just wanted to try and illustrate what you were showing. I had a nice model that we picked up from the AO basic course. This is just I don't know how far I have to be away for you guys to see this. So I have a humerus here in my left hand held together with some rubber bands to the forearm. And Jeremy, can you go to that reduction slide you had? So what he was showing is that, maybe if I do this sideways, we know that typically the fracture is here at the distal humerus, and that this distal humeral component is most often in an extension deformity.
Yo,
So
hold on one second. Let me stop sharing and you can be bigger.
oh yeah,
There you go.
okay.
You're good.
So we know that most typically the fracture is here in this supracondylar region, and the distal segment of the humerus has gone into a extension deformity, meaning it's flexed out the back or extended out the back. So what Jeremy was describing is typically you're going to be in the operating room and you're grasping the forearm and you're pulling down, and by pulling down you're actually distracting the elbow joint, and through all of the intact ligaments that attach the proximal ulna and the radius to that distal humerus fragment, instead of distracting through the elbow joint, as you can see is happening here with my model, those ligaments are intact. So instead it will pull through the fracture that's there. And then with a little bit, you're typically going to be in a little bit of flexion, like Jeremy said, and then pulling, you are then going to add stability, because remember this hinged posteriorly, it opened this way. So you add stability by pulling it and then flexing it back up into position. And what that does is I actually just broke the rubber band. So I broke the child's arm. What that flexion moment does is it coaps the two ends of the fracture together, so that for a temporary moment in time, as long as you hold it like this, it's stable, it's not going anywhere. And then you're going to rotate the arm into a way that you can hold, typically with one hand, especially for those who are more fortunate than I am to have a large hand. You can hold the whole arm in one hand, so that then you can operate a drill or wire driver in order to be able to introduce wires from the lateral side across that fracture site. Does that make sense? I don't know if I'm getting the angle right.
No, that's a good explanation. And again, remember back to our initial fracture and basic science description of how the bones actually break, is that when this bone breaks an extension, you're going to have comminution posteriorly with a tension failure anteriorly, which means you're going to have a straight fracture line. So as you flex up and you go to bring the bones back together through the ligamentotaxis, the capsule, the ligaments, everything pulling together, you're going to have that smooth fracture line anteriorly that you're going to reduce and have stability formed by putting that tension across with the elbow flexion.
So Jeremy, go ahead and finish your summary, and then Yazin, I haven't forgotten about you. We'll come back to that question. It's a great question.
That was a nice touch, Joe, with the model.
Yeah, my model already broke months ago, so I just have separate bones.
I got a spine here, a foot, pelvis, tibia, so no elbow.
I've got a skull from a plastics rotation.
Alrighty, so let's just go through a summary. So that we got a couple of questions here. So the first question is, what location has the most physeal growth? Coming in hot. Alrighty, let's end this. Alrighty, yep. So you guys did great. It's the distal femur. If you remember here, I showed you guys this image. And so if we're just looking at the distal femur, if we're just looking at the femur in general, 70% of the growth is from the distal femur compared to 30% of the proximal femur. If we're looking at the tibia, most of the growth is at the proximal tibia. If we look at the humerus, most of the growth, 80%, is from the proximal humerus. And then the distal radius is 75%. And again, a good way to remember this is just think of someone sitting in a bathtub, and it's a small bathtub, so they have to flex their knees, keep their hands out of the water. Anything above the water is going to be your more faster growing physis. And any fracture that's near that faster growing physis is going to be able to allow for more of a deformity and more of a reduction potential, or a potential of correcting that deformity as the patient grows. So
meaning that the physis will adjust for the angular deformity caused by the fractures, so that over time the alignment will restore.
yeah, we didn't talk about that today, but majority of proximal humerus fractures in kids we treat non-operatively, and the reason is 80% of the growth is from the proximal humerus. So you can accept a really good amount of deformity in young patients, and they're just going to correct that deformity as they grow. Alrighty, let's go on to this second question. So how would you classify this physeal injury? This is a distal femur we didn't talk about, but what type of injury to the physis do you guys see here? And again, so this is a AP and a lateral. The physis is here. So look at the way it's displaced. Look at the individual fragments. Look at the more proximal aspect of the distal femur and the epiphysis. Try to see if you see any fracture lines going through the metaphysis or the epiphysis. That will give you some help to answer this question. All right, let's just end it. So
this was a tough one.
Yeah,
this is a really tough one.
So Joe, you want to go through this?
Yeah, I mean, I'll be honest with you, I don't even know what the right answer is. I put a Salter Harris 1 because I can't see a fracture line on my screen. You can, this is a little bit, if I'm right, and I am hesitant, I could be wrong, maybe there's a fracture line that I'm not seeing. You can have a Salter Harris 1, that results in a significant amount of deformity. It's basically a transphyseal dislocation, meaning there was just a shearing injury. Oh, I see you bolded it, so you agree with me. Okay, so this is a Salter Harris 1, so it just shears off straight through that physis, and it's basically, it just dislocates through the physis. There's no fracture that extends into the epiphysis near to the joint. There's no fracture that extends into the metaphysis or into the diaphysis, making it a Salter Harris 2. And there's no fracture that starts from the metaphysis and extends down through and across to the epiphysis, making it a 4. So the only question then is, oh, well, could it be a 6? Is it a crush? And the mechanism here, you see that it's basically, you can just imagine that it just slid off into outer space. So that was more of a shifting motion. It was a shear that happened instead of a crushing component.
Yeah. So you can see here, this is the part of the physis on the AP here. And then the other part is somewhere here. Can't really see it. So that's completely sheared off. And if you follow this, this is, again, part of the physis, and then the other part's here. So like we mentioned, you can either have just a subtle injury as a Salter 1, just with some separation of the physis, or you can have a more devastating injury like this, where Joe's pointed out it can shear. I don't know how to erase, reset this. Did that go away or no?
No.
So while you're working on that, so Fernando asked, how would a crushed physis look? How is it always obvious comparing to a Salter Harris 1? And I'll be honest, it's difficult sometimes, and it's going to be very difficult to describe in words. If you think about how x-rays are projected and how you see different shadows, things that are more dense show up as a brighter white, and things that are more or less dense are radiolucent, they show up less bright. So if you know what the bone that lives immediately adjacent to the physis on either side of the physis should look like, then you can know what it would, when it would be different if it is crushed. Because when bone crushes in on itself, think about taking your kitchen sponge and how spread out it is, and you squeeze it and crush it down, it becomes more dense, right? So that's what's happening to the ends of the bone that are adjacent to the physis. That bone becomes crushed, and so it becomes more dense, and so it becomes more bright white on an x-ray. And so you can pick up that crushing component. And sometimes there's also some subtle comminution and fractures, and sometimes it's not just pure. Maybe there is also a little fracture line, but it's that attribute of, you can tell when bone is crushed in on itself because it gets more of a dense appearance.
Additionally, you'll also be able to see somewhat similar to a buccal fracture, what as Jeremy showed earlier with a distal radius fracture. If you're looking at it on the coronal plane, you will see some ruffled edges along the sides of the epiphysis. And then again, you can't take for granted that you'll have a physical exam to go along with it. So if you see any irregularity in the physis and there's no pain, it's unlikely that you have a crushed physis. If you have an x-ray that looks predominantly normal with the bones lining up, the physis is present, but it just looks a little weird, but there's significant tenderness along that spot of the bone, it's likely that you have a crushed physis. That's something that you want to monitor and be on alert for growth arrest down the road.
And then just one other thing I just wanted to point out, just came to my thought process now is, so say what I'm drawing out here is a fracturing line here through the metaphysis, so a Salter 2. Can you guys think of how you would fix this? It's similar to what I was describing about the Tillot fracture.
Oh, that's perfect, because this is going to tie back into Yazan's question.
Good.
Yep, definitely.
What kind of screws would you want to use? Would you want to introduce it medial to lateral or lateral to medial, and why? And maybe, I don't want to put you on the spot, but maybe if one of the incoming interns want to give their answer and reason through it.
If they don't, we have an actual intern with Ari here, so.
Yeah.
No, we can put him on the spot. We can do it.
Ari. I hope you were paying attention.
I'm sorry. What was the question?
Ari, you can defer to an incoming intern first.
Last couple of minutes.
So this is, I drew out here a Salter 2 fracture of the distal femur, with a fracture line coming through the metaphysis and then exiting out through the physis. How would you want to treat this? What type of screw would you want to use? And would you want to introduce that lateral to medial, medial to lateral, anterior to posterior, cranial to caudal, caudal to cranial? You want 4 screws? You want a plate? You want pins? You tell me.
So, I would want to use a screw from medial to lateral, yeah, I guess so. We're not seeing that Salter Harris 1 anymore. It's just
there's a new example, Salter 2. We have this.
So I probably used a lag screw medial to lateral.
And what's your reasoning to do that?
So
Threaded, fully threaded.
I guess I would use a partially threaded and do lag by design for this. But my reasoning from going medial to lateral, kind of like when you're putting in a traction pin, you want to go from known to unknown. and you want to avoid any damaging any neurovascular structures. So that's the safest route.
Love the thought process.
Yeah, I agree with you 100% on that safety issue.
What's the biggest and most visibly obvious difference between a lag screw and a traction pin? When you're just staring at the patient's knee and they have a traction pin across their knee and they have a lag screw across their knee.
I mean, the traction pin is coming out completely.
Exactly.
Okay. Yeah. Yep.
It goes through the skin and through the soft tissues on both sides. So
it goes through blindly on one side and somewhat protected on the other side.
Right. So with a lag screw, I mean, your thought process could not have been more perfect. But with a lag screw, we don't have to worry about those critical danger medial structures because the lag screw is not going to go all the way out through the other side.
Got it.
So we have the luxury of being able to think more just about the mechanics in this situation and don't have to think about whether it's going across. So that bearing in mind, keep your answer, change your answer.
So I'll change my answer according to what Dr. Hreha was talking about before with trying to hang a picture on a wall. It seems like you'd have more stability if you went from lateral to medial in this case, but attaching the smaller fragment to the large fragment.
Awesome.
Yeah. So if I drew out a screw here and it's partially threaded and say if you do medial lateral, you're only getting, say, 4 screw threads. If you do it lateral to medial, and again, I agree with you 100% on partially threaded, we can get 1, 2, 3, 4, 5, 6, much more screw threads. We can go
32.
We can put them all the way up until
all the way to 32.
So we have a much more screw threads engaging this bone, much more stability if we introduce it lateral to medial. And this fragment here, the smaller fragment, is called a Thurston-Holland fragment, and it's very specific to type Salter-Harris 2s. And again, if you guys are noticing, we're only doing lateral to medial or medial to lateral because we're staying away or out of the way of the physis. So that's opposite of, say, I mean, now we're getting into distal femur, but for this injury, a Salter-Harris 1, the way this is fixed is we reduce it and then we have to stabilize that joint now, or I mean, sorry, that injury through the physis. So the way we do this is because it's through the physis, we need to get some type of stability or fixation through the physis. And the way we do that is through pins, and we cross the pins. And so that gives us, we use smooth pins to help lessen the injury to the physis, but we cross them to give better stability, and we have to go through the physis. But if it's a Salter-Harris 2 or 3, we're staying out of the physis with any of our fixation.
So, Jeremy, Yazan asked earlier on your Tolo fracture, or maybe it was on the triplane part, and it applies perfectly to this part. Well, whatever. So,
want to go back or stay there?
Either way. So he said, how do you make sure the screw clears the large fragment so that you get good compression? And I think another way of saying it, if I'm understanding his question right, is how do you make sure that you're actually compressing the fracture site and not leaving your threads engaging both fragments? Yeah. And that kind of goes back to, some of those other concepts we talked about. We've talked about lag by design. We've talked about lag by technique. We've talked about picture to the wall to the picture, all of that. So how do you kind of tie all that together?
Yeah. So if you're doing an open reduction, you can kind of see where your fracture is. But if you're doing stuff more percutaneous technique, you're going to rely on your fluoro. And so you can see where your fracture line is on your fluoro. And so I just drew it out here. So
For anyone who hasn't spent any time in the operating room, if we have any PGY1s, fluoroscopy, intraoperative x-rays.
yeah. So we're localizing, we're seeing where our fracture is on our intraoperative x-ray, and then we know where that is, so then we can have threads past that site. So if we're doing a lag by design, the screw, the companies that manufacture the screw are determining how many threads, and there's different amounts of threads for different screws. Some are half the distance, some are quarter of the distance, third of the distance. So to get a more mechanical stability, it would be best to get screws exactly once you get past the fracture, but you want to make sure just your screw threads are past your fracture site. So you're just relying on intraoperative imaging.
Again, that also goes with knowing your implants and knowing the screw sizing that is available. Again, screws come with different lengths of threads in terms of the partially threaded design. So then in terms of pre-op planning, know how much bone you're trying to capture with that screw to see whether it's something that you adequately can get all of your threads across and adequately compressed. Or if that's not the case, you may need to be going down the lag by technique road rather than trying to use threaded or partially threaded screws to get that compression.
Going back to the chat, there was a little bit of debate, a little bit of toying with ideas of lateral to medial, medial to lateral. In that example of the distal femur you gave, some people were talking about avoiding the fibular perineal nerve. Just to discuss that at that level, meaning that craniocaudal dimension, if you look at the fibular neck down at the tibia plateau, the fibular nerve has coursed from posterior to anterior. It wraps around the fibular neck and then it splits into the deep and the superficial perineal nerves. At the much more cranial level above the knee joint line where we're talking about our fixation, that fibular nerve, or that nerve is actually still the sciatic nerve, or maybe it's right at the takeoff, and that is located much more posteriorly in the soft tissues. So we should be with reasonable accuracy able to avoid that entirely, unless we're just in outer space with our screw. Dylan asked, is there a role for a buttress or anti-gliding plate in kids? Love it. We're getting some biomechanics stuff in here. Who wants to take that one?
I mean, you love that topic, so.
Joe, that's all you.
So
yeah.
a buttress or an anti-glide is a fantastic way of neutralizing shear forces. Shear forces meaning that when you have these two pieces of bone that have slid past each other, it's not really a compression or an axial load. It's not a bending moment. It's that translating moment that happens, and an anti-glide neutralizes that very, very well. Is there a role for it in kids? I suppose you could use it, especially in like if you had a distal femur fracture that had a Salter Harris 2, especially with a very large metaphyseal spike. We call that the Thurston-Holland fragment. You could put an anti-glide on that. And there would be nothing technically wrong with it as long as your anti-glide does not violate and engage the physis. The more pertinent question is not can you use it, but do you need it? Kids have, in operating on kids, we have the luxury of relying on their biology, and kids have this tremendously robust periosteum around their bones, which it's really, you can't really understand how robust it is until you're in the operating room. Even when you're trying to reduce a kid with a displaced fracture and you can't figure out why it won't reduce, and it's really hard, and really oh, it's the periosteum. It's not until you get in the operating room and you actually cut the periosteum with a knife and you see how thick it is that you really appreciate it. So in this type of fracture, once you get it back in alignment, and in addition to the periosteum, they have such good bone quality. Once you get it back where it goes, it stays there pretty well. And usually you can get it to stay there with much less invasive. You don't have to do as much. You would have to do a full incision and a full approach down to the bone to put an anti-glide, and it just doesn't need that.
In general, kids heal extremely well. So sometimes you can get away with a little bit less of fixation construct in pediatric patients because of that reason. In adults, we might have to do more larger dissection and larger constructs to increase stability. Any other questions? Or I think I have one more question. Let's go on to question.
There was a student who had asked about getting the prior lectures. Lindsay, do you have the email for this one? If not, I'd be happy to forward it to you. If anybody wants to see the prior lectures, there should be a hyperlink for each of the individual lectures in the bottom of the email. Two hyperlinks. In fact, one is just a PDF of all of the slides, and the other is a recording of the lecture. Lindsay, if you don't have it, you can email me. I'll type my email in and I'll forward that all and we can add you to the list.
Or you can just type your email address in the chat and we'll.
Yeah. Shut up, Jeremy. Yeah, that makes more sense.
All righty. All right, last question. So what type of supracondylar fracture is this? And then part 2 is how would you treat it? And again, look at this closely. This is a tricky question. Kind of try to eliminate things if you can, narrow it down, and then come up with your answer. Actually kind of want to get Galloway and Thompson's thoughts on this before I even show the results.
Well, what I would do or what our attendings would do. Because that has changed since we were interns and went through our intern surgical skills.
Yeah.
And
what are we talking about?
is
Oh, I see.
this X-ray right here.
So this
is what I wanted to bring up. I wanted to bring this up.
This is controversial. There's maybe 2 correct answers here. Tough question.
So
give it another couple seconds and then.
Yeah. I'll let Jeff go at it first.
We're about 50% of voters, so let me just get a couple more.
Okay, yeah. People are putting emails in the chat, so we'll give them some time and get back to the question.
Yeah.
So these are all people who are not on it. Oh, maybe these people found it through the Instagram. That's awesome.
Yeah. Maybe I should put a post up saying if you're not on it, you can email us.
Just tell them to comment on the post.
Then you're sort of, well, I don't know, up to you.
Yeah, we'll see. Alrighty, let's end this.
Okay.
Let's show. You want to show the results first, or you want to talk about it?
Results are locked in. Let's see what people are thinking. And then we'll go from there.
Results are locked in. There we go.
Okay. So everyone looks like, or for the most part, called this correctly. It's a type 2 supracondylar fracture. You see that there's a cortical defect anteriorly and the capitellum is slightly posterior. Drawing your anterior humeral line, it may catch a little bit of the capitellum, which kind of makes you think whether this is a type 2A versus 2B. Again, we said 2A is something that is not operative. 2B is generally at this point operative. And really kind of the treatment comes down to your comfortability and, again, attending comfortability in performing reductions on these in the emergency room. As you're putting a cast on for this, you can turn this 2B into a 2A with an anterior directed force over the olecranon. As you're putting your cast on, it can bring the capitellum anteriorly, so it will be bisected by your anterior humeral line. Those kids will likely do fine. They will not have any type of residual deformity from the fracture, and take their cast off and they'll be moving around okay. Conversely, if you do want to operate on this, you could put this in a splint, immediately say that it is operative, and take it to the operating room, perform the same reduction maneuver, hyperflex the elbow because this patient will be asleep, and put pins in for added stability to truly restore anatomic relation at the elbow. Again, this is a controversial area where you could cast it, you could pin it. I probably would try putting a cast on, putting a bit of a mold on it. It's not a true reduction. You don't need conscious sedation for the patient. But again, know your attendings. Some of them want to pin these from the get-go.
Yeah. Galloway, you want to comment, or should I show what I drew the anterior humeral line as? And
oh dear God, I always want to see your drawings. Yeah, go for it.
well, it's going to show what I thought was kind of the answer, but
I think I agree that this falls in the 2B category.
right. So, I mean, this is what I drew the line as. And so I can see, as if you guys notice here, there's this little kick anteriorly of the anterior humeral line. So you can draw this kind of however you think fits it best. I kind of drew it here. I kind of followed more proximally down, and then this is my line that I drew. So, I thought it captured a good piece of the capitellum, which is this here. If you draw the line a little bit with that, let me go back here. If you draw, you can make an argument that you draw the line following this, and again, this isn't a straight line, but it intersects less of the capitellum. So you can make a good argument that, yeah, it's the capitellum's more posterior. So what were you thinking, Joe?
So I'm going to admit that I fall a little bit more on the bias of operative treatment when there's concern. But my bias is I don't think it's so much about where does the line lie, and can you push it, reduce it, and push that distal fragment anteriorly enough so that the anterior humeral line bisects through the middle third appropriately. The question is, can you hold it there? And this brings up a really cool point about how did we come to start pinning these, and what is the problem with casting them? And if you remember when I was showing that model of the flexion, and how when you reduce these in the operating room, once you've pulled it out and you flex it over and you jiggled it back and forth and you got it aligned and then you flex it up, it stays put. So when you're holding it in flexion, it stays, it's reduced, it's stable. So when you're putting a cast on, these patients need to be near to 90 degrees. And the farther into flexion you put the cast, the more stable it is. And if you can push it with your thumb and put it back where it goes, and you put it at 100 degrees or 105 degrees, it's going to stay, or 110, it'll stay, and it will stay there in a cast. The reason that is not okay to do is because putting a patient in a cast in a hyperflexed position will cause ischemia. It will cause the brachial artery to thrombose, and it will cause full necrosis of the forearm. And these patients will get what's called a Volkmann's ischemic contracture, where basically the tissues around the forearm, or maybe some, collateral blood flow will make it distally. Maybe the whole hand won't quite die, but they will get a contracture, a significant, devastating contracture from that injury. So basically, the deciding factor, do you need to take this patient in the operating and put pins in, is, can I keep it reduced like this, or do I need to go like this to hold it reduced? And if I have to go this far to hold it, then I should stop, take him to the operating room, and then put pins in. And so that for me is sort of and maybe that's just my bias. I would be terrified, afraid of trying to be overly aggressive and push it and try and hold it reduced with a cast. Now the flip side is really easy to push on it, put it at 90, put it in a cast, see them in a week, and if it moved again, then you say, well, this didn't work, and then take them to the operating room instead of being aggressive and like trying to flex it and hold it there. So there's really a lot of ways you could paint that picture.
Yeah, I think you bring up a great point about casting it. And after we fix these and put closed reduction percutaneous pinning in, we cast them in just some slight flexion, not up to, normally when we try to cast things in long arm cast, we go for 90 degrees, but we're relaxed after we flex it for those reasons that Joe was just talking about the blood flow.
And that brought me to another thing just that I wanted to mention for students and how you should begin to build your mindset about how we treat things. This is not unique to orthopedics. This is for anything related to surgery, but we hope that all of you are going to go into orthopedics because it's very clearly the best thing. And so when you're building in your mind and you're looking at x-rays and you're thinking, what am I going to do for this? You should always build your treatment plan in a stepwise fashion. You should always think first about non-operative treatment. Can I achieve the goals of care with no surgery? If the answer is no, or with no immobilization, that's the most benign thing that you can do to a patient. Just give them some pain medicines or physical therapy or whatever. And then if the answer to that is no, maybe you should immobilize them. If that cannot achieve your goals, then maybe you should put a pin in something that's like a very minor surgery. If that can't achieve your goals, it's too unstable, then maybe you should do a more limited, slightly open surgery or put a nail down something or something. And if that can't achieve your goals, then you have to fillet the thing open and put it back where it goes and put plates and screws in. That's how you should sort of build your mindset.
Yeah, exactly. As orthopedists, as surgeons, we love to operate, but there's risks involved with operating. So if you can treat something non-operatively and avoid those potential risks, then that's the best for the patient. That's the last question I have. Any other questions from the audience? Nope. Alrighty. So again, next week, same time, 7 p.m. We'll do another lecture. Might be another pediatric themed one, but we haven't decided yet. Again, if you guys aren't on the email list, just comment your email. We'll get you on that. Follow our Instagram account for some more information, and we're trying to put a little bit more content on our Instagram story with some questions to tie in from the lectures and just some interesting points that we, an interesting case we did that day or something we read about. So feel free to follow us for some additional information and just get a little bit better sense of our program and our residents and some activities we do outside of work as well.
Jeremy, did you put the plug?
You can comment. Let me check.
So how can people find more stuff on the? I think Joe put it in the chat.
Yeah. I put it in there.
There is a Instagram page that we maintain. You guys can follow. It's at njms.orthopedics.
All right. Thanks for everybody for joining, taking their time out to spend with us. Appreciate it. All right.
Thanks, Corey. We'll add you.
I'm gonna stop recording.